Hi, I'm Dr. Dalen Richards, and I have a PhD in genetics with a focus on gene therapy, and I'm currently a fourth-year medical student at the Washington State University Elson S. Floyd College of Medicine. I'm excited to share this case report titled "The Pursuit of Broad Genetic Testing in Molecularly Confirmed Atypical Neurofibromatosis Type 1" that I worked on with pediatric geneticist Dr. Drea Peterson at Legacy Emmanuel Randall Children's Hospital in Portland, Oregon. This patient came to genetics at 2 months of age, meeting the clinical diagnosis of NF1, including the presence of more than 10 greater than 5 millimeter cafe au lait macules in the setting of a strong family history of clinically diagnosed NF1, including 2 first-degree relatives, his brother and his mother, as well as several family members on the maternal side, as pictured in the family pedigree on the top right. Birth history included a full gestation in a pregnancy complicated by intrauterine growth restriction. As genetics continued to manage his care, his phenotype developed, as shown in Table 1. By 2 years of age, his phenotype consistent with NF1 included a large inoperable neck plexiform treated with selumetinib, MRI, imaged here, axillary and inguinal freckling, scoliosis, tibial dysplasia, an impressive pectus excavatum, developmental delay, and short stature. His phenotype inconsistent with NF1 included congenital hearing loss, a large Becker nevus, photographed here, bilateral proptosis, dysplastic and hypoplastic toenails, overlapping toes, coarse hair, and growth restriction both pre and postnatally. Of interest, his small stature was unusually pronounced at the less than 0.01 percentile for length, as you can appreciate in the growth curves displayed on the bottom left. This is a z-score of less than 3.57 at 2 months of age in the setting of normal feedings with formula. Of note, his mother with NF1 reached a maximal height of 5 feet 11 inches, and his unaffected father is 5'10". Interestingly, his older brother, also with NF1, has developed along the 90th percentile curve for height, contesting a possible link between this particular familial NF1 variant and this patient's pronounced growth restriction. At 1 year of age, single gene analysis of the NF1 gene was performed and revealed a heterozygous pathogenic truncating variant at exon 21, which was not surprising given his clinical features. However, due to this pronounced and atypical phenotype, we pursued broad genetic testing with trio whole exome sequencing, which revealed a maternally inherited IGF-1R pathogenic variant, confirming a dual diagnosis of neurofibromatosis type 1 and insulin-like growth factor resistance in both the proband and the mother. IGF-1R encodes the insulin-like growth factor 1 receptor, which mediates the effects of insulin-like growth factor 1 hormone that is important for growth during development, as well as anabolic metabolism throughout life. Interestingly, these two disorders share several phenotypic findings, including pectus excavatum, developmental delay, psychiatric disorders, and of note, this unusually pronounced short stature. While the therapy of IGF-1 resistance is controversial, specifically growth hormone, it is nonetheless a therapeutic option that would have otherwise been unavailable to this patient. While the clinical significance of this dual diagnosis is debatable, it allows for a more thorough understanding of this patient's prognosis and provides meaningful contributions to long-term management. In conclusion, the presence of dual diagnosis in patients with a previously confirmed genetic diagnosis is greater than 5%. Yet the willingness of providers to pursue additional testing with a confirmed diagnosis is limited, especially when the pronounced phenotypic findings are encompassed with the current diagnosis, as in this case. Given that NF1 has a long-standing history of complex phenotypes, we argue that there should be a lower threshold of clinical suspicion for the pursuit of broad genetic testing and more severe presentations of NF1 to test for the possibility of a dual diagnosis. Thank you for your time. Please do not hesitate to reach out to me via email at dalen.richards@wsu.edu for any further questions. My contact information is on the bottom left of this poster, and I hope you enjoy the conference. Goodbye.